Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. In this presentation we're going to review neurology trauma, which essentially includes head injuries and spinal injuries. Okay, now before we go into looking at trauma, I think it's important to review the Glasgow coma scale. Or you should be aware of some sort of scoring system that can allow you to determine how severe a brain injury could be, regardless of the cause. Now the Glasgow coma score has got three components to it: eye opening, verbal response and motor response. And first revealed by Teasdale and team in 1970. And then published in 1974 as a practical scale. Now, when it comes to the Glasgow coma score, the best possible score for eye opening is 4, where the patient or the victim opens their eyes spontaneously. The worst is 1, not 0, 1, where no eye opening occurs regardless of the stimulation. Then you've got the next section, which is verbal response. And this basically refers to being alert and orientated to self, time, place and situation. And if they do that, the victim then scores 5, the best possible score. If there's no verbal response, the victim scores 1. Now remember, if the patient is in ICU and they are unable to make a verbal sound because they are intubated and ventilated, that doesn't mean there's no verbal response. It just means that the tool has to be modified to suit that situation. When it comes to the third, which is the motor response, the best score is 6, which means the victim, the patient, is able to follow commands. So lift your right arm, squeeze my hand with your left hand, and so forth and such. The best possible score is 6. The worst possible score is 1, which means they do not follow any commands, they don't respond to any stimulation, whether it's now painful stimulation, local or generalised. Now, the worst possible score in the Glasgow coma scale is 3. Not 0, is 3. The best possible score is 15 out of 15. Now, this is consistently used for all head injuries and even possibly spinal injuries, which may be associated with a head injury. I think it's also important to remember what intracranial pressure is. Now, intracranial pressure, as it says, it's pressure in the cranium, which means in the skull. And this is created by 3 components: the cerebrospinal fluid, the brain tissue itself, and the intravascular blood volume inside the skull. They're the 3 components. And the brain is very clever at now manipulating these 3 components, except for brain tissue. It can't reduce brain tissue, but it can reduce intravascular blood flow inside the head, cerebral, up to a certain point. It can reduce or decrease the production of cerebrospinal fluid up to a certain point. These are called compensatory mechanisms. When it can no longer do that, decompensation occurs and intracranial pressure escalates, skyrockets, becomes abnormal and potentially problematic. When it comes to brain tissue can increase. Tumours, collections of blood called hematoma, increased in cerebrospinal fluid, hydrocephalus, and so forth. But if intracranial pressure is measured in millimetres of mercury, it's normally 0 to 15 millimeters of mercury. And typically in adults, in a supine adult, it's 5 to 10, standing 0 millimeters of mercury. Anything above 15 is potentially problematic. What are some of the causes of increased intracranial pressure? Well, a head injury. Because again, with all these pathophysiological components, you get an increase in intracranial pressure via cerebral edema. And as a consequence of cerebral edema, the brain swells and this increases intracranial pressure. So yes, head injury, a tumour, encephalitis, meningitis as a result of infections, hydrocephalus, CSF, cerebrohemorrhage, subdural hematoma, subarachnoid hemorrhage, intracranial hemorrhage. These are all essentially tissue collections. Then you've got cerebral edema or cerebral aneurysm, which is now tissue again. Hematoma, blood, hypertension, potential damage, and stroke. These can all increase intracranial pressure. Now, with increased intracranial pressure, there are clinical manifestations, and the most common symptom is a headache, described by victims as the worst headache they've probably ever experienced in their life. Nothing like they've ever had before. With increased intracranial pressure in a triad, Virchow's triad, there are 3 clinical manifestations. Typically, an increase in blood pressure, shallow, slow breathing, and bradycardia. So, hypertension, bradypnea and hypoventilation, and a slow pulse, a slow heart rate, bradycardia. This can also result in mentation issues such as confusion, changes in alertness and orientation. The victim can have blurred vision, photophobia, even changes in peripheral vision because of pressure on the optic nerve. As we mentioned, hypertension and hypoventilation, nausea, vomiting, changes in their behaviour, so personality may change. They may demonstrate weakness and fatigue, paresis, whether it be hemi, as is seen in a stroke, dysphagia, difficulty in swallowing, dysarthria, difficulty in speaking, also as demonstrated now by stroke issues, mobility issues, fatigue we've mentioned, and insomnia, and more. So what are some of the risks of developing increased intracranial pressure? Well, intracranial pressure can be increased as a result of cerebral edema, as a result of injury, which could occur as a result of hypertension, having had a stroke, meningitis, encephalitis, anything that can cause a head injury. And the complications associated with increased intracranial pressure, and these risks could be related to seizures, ongoing stroke, ongoing neurological damage, and potentially death. I think it's important to review what brain death is, because it's a concept that doesn't seem to be understood even in some of the clinical areas. Now, brain death, as it says, the brain is dead. It's completely dead. It cannot be reversed. There's irreversible brain damage and the whole brain is dead, which means the patient can't survive. They will survive periodically with advanced life support interventions, but take them away and they are dying. They're not dying, they're already dead. So make it clear. Brain death is defined as irreversible loss of all functions of the brain, including the brain stem. And in the brain stem, you've got cardiovascular support, respiratory support, as well as numerous other vital organ supports. Now, the three essential findings in the brain death are coma, absence of brainstem reflexes, and apnea. When you look at the diagrams, for example, here you've got a scan and it's showing you that really in brain death there's no perfusion whatsoever. The brain is dead. Here in an angiogram, you're seeing here no dye going up into the cerebral circulation in the second image. The first image is normal. And if the brain doesn't have a circulation, then it's dead. There are numerous signs of brain death, and there is criteria for brain death which has to be reviewed by medical experts. Now, signs of brain death can include the following. The pupils are fixed and dilated and do not respond to light. The person or victim shows no reaction to pain, and they have a Glasgow coma score of 3 out of 15. The eyes do not blink when the eye surface is touched. This is the corneal reflex. The eyes don't move when the head is turned or moved. This is called the doll's eye reflex. The oculocephalic reflex. The eyes don't move when iced water is injected into the ear. This is the choleric reflex, also known as the oculovestibular reflex. Now, brain death criteria cannot be determined until the patient now is off all sedation, off all pharmacological paralysing agents such as neuromuscular blockers. Their acid base and electrolytes and oxygenation provisions are all normal or as close to normal as possible in respect to their condition, because again, the brain cannot be assessed for criteria of death unless all physiological parameters and all sedation, whether they be opioid, benzodiazepine or neuromuscular blockers, are out of the patient's system. Here are some other examples of brain death criteria. They have a coma, absence of motor responses, no reaction to light from pupils, and the pupils are dilated and fixed. There's absence of corneal reflexes, choleric reflexes, absence of the gag reflex, cough, swallowing, absent. In essence here, I guess if we're going to be looking at this here, if it's a child, then there would be an abscess of now the sucking or rooting reflexes. The apnea test is positive, which means there's an absence in the respiratory drive, and there's a PaCO2 that will be recorded that is greater than 60 millimeters of mercury. There's an interval in most countries between the evaluations, and typically there are 3 experts at consultant level that will now determine brain death criteria. They do it independently and then come to a conclusion with their findings. This is the corneal reflex, for those of you that don't know. Now, all the reflexes basically refer to the cranial nerves in most cases, or brainstem reflexes. So the corneal reflex is controlled by cranial nerve 5 and 7. 5 the trigeminal and 7 facial. And this is really the blink reflex. And it is absent in brain death. Test your own. Anything approaches your eye, you will reflex and blink. This is protective. Then you have the oculocephalic reflex, which is referred to as the doll's eye reflex. We all have it. This is a normal reflex. In someone with brain death, it is absent. So a positive doll's eye reflex, where the eyes move in the opposite direction to the head movement, indicates intact brain stem. A negative doll's eye reflex, where the eyes remain midline or move in the same direction as the head movement, indicates severe brain stem dysfunction. But typically, they remain fixed midline and don't move, as is indicated in the middle diagram. Then you have the oculovestibular reflex, the caloric reflex. And this is where the examiner irrigates, or not injects, but inserts very cold ice water, about 20 to 40 mils, and what should happen is a nystagmus should occur in a normal person with a normal brainstem. And this will lead to slow movements of the eye towards the ear being irrigated. In brain death, this doesn't occur. The eyes do not move. The eyes do not deviate towards the side of the injectate, ice water, in the ear. There's also an apnea test. An apnea test is where the patient or victim in the intensive care is being ventilated. And what typically happens is the patient is disconnected from the ventilator, a catheter with a flow of oxygen at 6 litres to 8 litres per minute, essentially providing 100% oxygen via a catheter, is inserted into the airway, the respiratory tract, to the level of the carina. On the monitor, the SpO2 is monitored. The patient won't be breathing. If they're breathing, they're not brain dead. And we will observe for chest wall, abdominal wall movement, or any sign of breathing. Now, typically, there will be no respiratory movement. The patient will be provided with 100% oxygen, so they shouldn't become hypoxic. The arterial blood gas that is taken after 10 minutes, the PaCO2 should be greater than 60 millimetres of mercury, or at least greater than 20 millimetres from their original baseline, which may be abnormal. Then afterwards, they're reconnected to the ventilator, and if it is greater than 60 millimetres of mercury, no signs of breathing, or greater than 20 millimetres of mercury from the baseline, then this apnea test is declared positive, and it's documented that there is brain death criteria met. Now, when we review head injury and spinal injury, this could occur as a result of multiple injury trauma, also known as polytrauma. And typically, multiple trauma or polytrauma means having severe injuries but greater than 2 body areas involved. So, for example, here it could be cardiac, respiratory, and neurological. And these injuries can cause severe bleeding, shock, burns, thermal injuries, contusions, and fractures. Now, the damage can involve the brain, the lungs, the spleen, the heart, the kidneys, the bowel, the spleen, and many more, multiple, poly. Multi-trauma can occur from falls, explosions, a terrorist attack, a physical attack, a fire, a crash, any violent events. Now, these traumas can cause brain injury, chest problems, multi-organ failure, blood loss, infection, permanent disability, and loss of limbs. Now, there are 4 major mechanisms of injuries, which we're not going to be reviewing all of them, but the most common mechanisms are blunt injury, penetrating injury, blast injury, and inhalational. And typically here, with severe trauma, people usually recover completely, and they do have issues which are ongoing, or they may have chronic long-term health problems as a result of it. Now, the common causes of polytrauma are falls, motor vehicle accidents, and assaults. When we look at head injury, now remember, your brain is your computer. Damage your computer and you've got an issue. So traumatic brain injury usually results from violent blow or a jolt to the head. It can be mild, moderate or severe. Now, mild affects the brain possibly temporarily, and you typically recover. But with more serious injuries, which result in bruising, cerebral edema, torn tissues, intracerebral bleeding, bleeding in general, hemorrhage, which can affect now other parts of your body in respect to physical damage to the brain. And as I said previously, these injuries can result in long-term complications or death as a consequence. What are some of the clinical manifestations? Well, we said mild, moderate, severe. With mild, you may just have a headache, nausea, vomiting, feel a little bit disorientated, have problems initially speaking, be dizzy, blurred vision, photophobia, tinnitus, ringing in the ears. Or they can be more severe, where you've lost consciousness for several minutes to hours, a persistent headache, repeated vomiting and nausea, convulsions and seizures, pupil dilation, whether it be uni or bilateral. You may even have CSF draining from the nose and the ears, indicating that severe damage has occurred to your skull. You may be fatigued. There may be weakness and more severe loss of coordination. How is this diagnosed? Well, initially, as always, history and physical assessment. And the Glasgow Coma Scale is a very good tool to assess potential severity of brain damage. Certainly a skull X-ray, CT scan, MRI, and if available in the intensive care, intracranial pressure monitoring. How is it managed? Well, management depends on how bad the injury is. But always, the objective is to prevent further damage. And in the emergency care, this is exactly what happens. The focus is on preventing any further brain damage. If it's now a head injury, maybe immobilisation of the victim, if it's related now to head or spine. Medications can limit secondary damage to the brain, such as now anticonvulsant medications, medications that now induce coma to decrease metabolic requirements, movement, Diuretics decrease cerebral edema, medications like mannitol. Then there could be surgical interventions to remove hematomas that put pressure on the brain, increasing intracranial pressure, repairing skull fractures, stopping bleeding, relieving pressure inside the skull if in intensive care, and again draining cerebrospinal fluid. Or even the surgeon creating a window in the skull that relieves intracranial pressure and provides a little bit more space, area for edematous tissues. The image that you see in front of you, this is now a ventricular peritoneal shunt. And typically this would be in someone, whether it be a child or an adult, that has hydrocephalus for whatever the reason. There are numerous management interventions. Another component of multiple or polytrauma is spinal cord injury. Now, the spinal cord, as the brain, is part of the central nervous system. And with spinal cord injury, that's damage to any part of the spinal cord and even nerves at the end of the spinal canal called the cauda equina, the coccyx area as well. Traumatic spinal injury can be acute, which is sudden, from a blow, dislocation, crush, compression of one or more of the vertebrae. It can result from now penetrating injury, such as a gunshot wound or a knife wound that severs the spinal cord or partially severs the spinal cord. And this damage can usually occur over days or weeks because bleeding and swelling, inflammation, and edema around the spinal cord continue. There are other causes of non-traumatic spinal cord injury, such as non-acute conditions such as arthritis, whether it be rheumatoid or osteo. It can be related to any form of cancer, tumours, infections, inflammation, and even disc degeneration of the spinal cord. And when you get these injuries, they're essentially the result of damage to the vertebrae, which are the protective structures that surround the spinal cord. It can be as a result of damage to the ligaments or other discs in the spinal column, or actually to the spinal cord itself. What are the causes of spinal cord injury? And I'm sure you know. Motor vehicle accidents, whether they be car, truck, motorcycle, pedestrian, they're the leading cause of spinal cord injury globally. Then you can have falls, which occur in the elderly. Acts of violence, which occur every minute of every day in every part of the world, whether they be penetrating, such as gunshot or knife wounds, or as a result of blunt injury from blows. They can also be the consequence of sports or recreational injuries, commonly diving into shallow water, being tackled in physical sports such as football, rugby, boxing. They can also be the consequence of diseases or infections which occur as a result of cancer, arthritis, osteoporosis, infections which result in abscess, and any form of inflammation around the spinal cord. They can also be associated with congenital anomalies, birth injuries, and these typically affect the spinal cord and the neck area. What are some of the types of spinal cord injury? Well, you've got incomplete and you've got complete. The incomplete may affect some motor and sensory functions below the affected area, but it varies. You've got three main, which are called anterior cord syndrome, central cord syndrome, and Brown-Séquard syndrome. Then you have complete spinal injury, where all feeling, sensation, and movement control are lost. These are the specifics, and these can be incomplete or complete, but I'm just going to go through the complete. You've got quadriplegia, quadra, 4, tetra, 4, and this is the most severe type of spinal cord injury because it affects every single limb, both arms, both legs, and everything in between. So that means it affects your arms, hands, trunk, legs, pelvic organs by this injury. And it's typically located in the cervical spine or certainly above T6, but a high injury is in the cervical area, typically C1 to C5, but it can be to C1 to C7. And this can affect, this will affect the respiratory muscles, breathing, and all arm, hands, legs, bladder, bowel, reproductive function. It affects every single organ in your body. When it comes to para 2, paraplegia means that only, typically, it affects your upper body. Above is okay, the lesion. Below the lesion is problematic. So, paraplegia means that the arms, hands, legs, trunk, pelvic organs are all affected by the spinal cord injury. And a lower injury is in the lower lumbar vertebrae, L1 typically to L5. What are some of the risk factors associated with spinal cord injury? Well, these are related to being male in comparison to females. Why? Probably because males seem to be more physically active and maybe take greater risks when doing physical things. Age, 50% of spinal cord injuries occur in the age group of 6 to 30. But after 65 due to falls, this increases the risk. Alcohol abuse, certainly recreational drug abuse, they account for about 25% of traumatic spinal injuries. Drinking and driving, recreational drug use and driving, drinking and speeding, drinking and doing silly things. And when I say drinking, I'm talking about drinking alcohol. Then typically engaging in risky behaviour, diving into shallow water, playing sports without proper safety gear, not wearing motorbike helmets or the proper appropriate protective equipment, not wearing seatbelts. These are all potential risks for spinal cord injury. What are some of the clinical manifestations of spinal injury? Well, it may be observed the neck is in an abnormal position following a motor vehicle accident or a fall. Extreme pain or pressure in the neck, head or back. Weakness or paralysis in any part of the body, numbness in the hands, fingers, feet. Loss of sensation, an inability to feel heat, cold, touch, maybe even pain. Loss of bladder and bowel control. Loss of movement. Exaggerated reflex activities, things like spasms of the limbs, impaired breathing, coughing, clearing of secretions, and changes in sexual function or sexual sensitivity. These are all clinical manifestations associated with spinal injury. What are some of the complications? Well, let's go right down to the bottom. Depression. How do you cope with this situation? Loss of bladder and bowel control. Risk of developing pressure ulcers or injuries. Circuit control. Quadriplegics will be orthostatically hypotensive. Decreased blood flow to the lower limbs. In both situations, risk of deep vein thrombosis, which could create a pulmonary embolus. There's something called autonomic dysreflexia, which basically means the sympathetic nervous system responds in a different way to noxious, terrible stimuli, such, for example, a full bladder, a full bowel, pain of any kind can automatically trigger a life-threatening hypertensive crisis. Breathing and coughing may be problematic, which will result in chest infections. Spasticity and spasms, flaccidity, and atrophy of muscles. I mean, regardless of whether you're a paraplegic or a quadriplegic, your muscles below the lesion will atrophy because you're not using them. There may be weight loss, and as we mentioned, muscle atrophy. There's also the risk of obesity, and as a consequence of that, cardiovascular disease, developing diabetes mellitus, renal problems, and so forth. When it comes to sexual health, well, men will not be able to have an erection and therefore will be unable to ejaculate. In respect to women, well, they can still have children because they're the conduit, essentially, but there may be changes in their lubrication in respect to vaginal secretions. Pain. Neurological pain could occur, and this is especially in incomplete injuries. What are the diagnostics? History and physical assessment are most important. X-rays, so therefore spinal X-rays, CT scan, MRI, and always follow up over a period of weeks to see if there's any improvement in the patient's condition or response to therapeutic interventions. What's the management? Well, there's no way to reverse damage to the spinal cord. Once the cord is damaged, it's damaged. However, as with all treatments, the objective is to prevent further injury. Because initially, there'll be what is called spinal shock. There'll be spinal edema, just like there's cerebral edema in a head injury. And this requires medical interventions to reduce things like inflammation, promote blood flow, prevent further damage. And again, the treatment really focuses on rehabilitation and empowering people to return to active and a productive life, if possible. At the accident scene, it's important to immobilise the spine using a rigid C cervical collar and a rigid board which the paramedics will have to immobilise and prevent inappropriate, potentially damaging movement. In the emergency room, the focus is always on basic life support and treating neurogenic shock. Spinal edema. In the intensive care unit, typically quadriplegia may be on a ventilator after being intubated, and again, further management to provide no damage or ongoing damage to the spinal cord area. So therefore, other potential complications could be related to temperature control, stool or urine retention, respiratory and cardiovascular support, and again, immobilization and prevention absolutely of pressure ulcers, which again, quadriplegic and paraplegics are at risk of. And typically, these patients should be managed in a spinal medical centre where there are neurosurgeons, orthopaedic surgeons, spinal cord management specialists, psychologists, physical therapists, specially trained nurses, and social workers who all have expertise in spinal cord injury. How do we prevent it? Common sense should tell you, drive safely and don't drink and drive or speed. Before you go diving into a pool, whether it be fresh water, whether it be in a river, whether it be in the ocean, make sure that you know that it's deep enough to dive into and there is nothing in the water that now is hidden. Prevent falls and take prevention in the form of precautions, protective equipment. Be sensible. Think sensibly. So let's review. What's the Glasgow coma score? Well, the Glasgow coma score is now a scale to determine the severity of a traumatic brain injury. There are 3 components to it: eye-opening, verbal response, and motor response. Eye-opening, the best score is 4, the worst score is 1. Verbal response, the best score is 5, the worst score is 1. Motor response, the best score is 6, the worst score is 1. The worst possible score that can be achieved, which is no response to anything, is 3. The best possible score is 15. What are conditions that may increase intracranial pressure? Well, conditions that increase intracranial pressure are anything related to your head injury, or even here, things related to possibly spine. But commonly, it's going to be intracranial pressure is inside the head, and this relates now to tissue, cerebrospinal fluid, and blood. Name 3 severe clinical manifestations of head injury. Well, the clinical manifestations are, more commonly, a severe headache. This can result in signs and symptoms that relate to vision, mobility, orientation, alertness, levels of consciousness. Name 2 common causes of acute spinal injury. Well, motor vehicle accidents and falls. And they can also include acts of violence, sports and recreational injuries, diseases and infections, and also birth injuries of infants during the labour and delivery process. Or they can actually be a result of now congenital anomalies. Well, that's it for this session. Thank you. If you found these Dr. Manny Learn Shops to be of any benefit, please recommend them to your colleagues and friends and subscribe. And that way you'll be notified of any others that may be available in the future. Thank you and God bless.